Definitely, it's my pleasure to be here with you. It's my third trip to India, my first trip to Delhi, I have yet to have a bad experience visiting your country, and I always am sad when I have to leave. We talk about tuberous sclerosis as a rare disease, but it's much more common than many people think. Definitely at a specialized center such as Ames, there are going to be cases that come through these walls and need care and need treatment. And so I hope that what we talk about today is useful to you as you take care of these patients that are so near and dear to me. You already heard that I have multiple relationships. None of these are really influencing our talk today, so I think I'll just move on. Because I'm the first speaker, I get to give at least a little bit of background. We know from studies that were done primarily in the United Kingdom were the best ones done, but there's been epidemiology studies done over the years. And so it's about 1 in 6,000 live births that we estimate that tuberous sclerosis is present. So we know that there are literally millions of people worldwide affected by tuberous sclerosis. And genetically, we'll hear a little bit, I can't remember, today we have more genetics talks, but it's something that it's 100% penetrant, but it does have highly variable expression, and I'll talk a little bit of that clinically. We've known the genes responsible for tuberous sclerosis now for over 20 years. A large consortium in Europe and the United States were responsible for discovering the two genes that cause tuberous sclerosis, TSC1 that's on chromosome 9 and TSC2 that's on chromosome 16. Many smart people that I can't take credit for figured out what these two genes do, and they are central to a signaling pathway that involves mechanistic target of rapamycin or mTOR. And it is this signaling pathway that tells cells whether it is appropriate to grow. And then as we started to study the brain and other more complex processes, we know that it's not just growth. Neuronal differentiation, neuronal signaling, many other processes also depend on the mTOR pathway. Now, in tuberous sclerosis, we lose control of mTOR, and so we have drugs that are available, everolimus and sirolimus, that are inhibitors of mTOR that we depend on for the treatment of tuberous sclerosis today. These drugs actually existed before we had the genes for tuberous sclerosis. They were investigated first as antifungals, and eventually they were used as anti-oncologic drugs. And we were able to repurpose them for tuberous sclerosis, building on all that previous experience in these other disorders, to where we have approved indications today. As a result of dysregulation of mTOR, every organ system can be affected. So there is not a specialist or a general practitioner here in this room for which tuberous sclerosis does not have a significant importance. I will focus on some very specific manifestations, but just know that every part of the body, every tissue has the possibility of being affected by this disorder to some degree. When we think of tuberous sclerosis, we think of criteria as major or minor. Major criteria are those things that when you and I come across them in a patient, whether it be by physical examination or by studies that we might undertake, when we see them, at the very top of our list needs to be the consideration of a diagnosis of tuberous sclerosis. It doesn't mean that there are other things that can do some of these things that we see here, but it does mean that the most likely cause that we will encounter for causing these major manifestations is going to be tuberous sclerosis. So these are the ones we can see in our physical examination, many different skin findings, and then we also can do an ophthalmologic examination and see sometimes tumors in the eye. And then the rest of them we depend on our imaging colleagues. Most of the time we're going to use magnetic resonance imaging. Certain instances we may use computed tomography or ultrasounds, but ultimately we may find that there's evidence of lung lesions, kidney lesions, heart lesions, and in the brain. There also are minor diagnostic criteria. These occur with, they are very frequent in tuberous sclerosis, but unlike major criteria, they also occur very frequently in many other disorders as well. So they're less helpful for us to hone in on specifically diagnosed tuberous sclerosis from the start. The reason why they are important, though, because as I said, there's variable expressivity, which means that maybe all of these manifestations may not be present at the same time in the same individual. And as such, we can use the minor criteria to confirm a diagnosis when perhaps there's not enough major criteria for us to know for sure initially. It's also important to appreciate the minor criteria because many of these things we may see in patients with tuberous sclerosis that if they did not already have a diagnosis of tuberous sclerosis, we may be more worried. For example, a hamartoma of the liver that we see here in the second panel below, that may be very worrisome for some sort of hepatic carcinoma, except if we know that they have tuberous sclerosis, our concern goes way lower because we know that that's a common occurrence and that's a benign lesion. And so that's what we see many things under here. Another common example that we'll deal with is polyps of the intestines. Colonic polyps in any person without tuberous sclerosis is a huge red flag for colonic cancer. However, they occur with very high frequency in tuberous sclerosis adults. And when we see them, we tend not to get nearly as excited or concerned about them unless they have other atypical features associated with them, such as rapid growth or irregular appearances. The other thing is to be aware of is that not everything goes wrong in tuberous sclerosis at the same time. Some things we will find present from birth or even before birth, and we'll hear about that later today. And then other things may occur only in adults, such as the lung disease, that it is estrogen dependent. And so it tends to occur almost exclusively in postpubertal females. There are some rare cases of adult males having LAM or this lung disease, but they are the exception to the rule. Half dozen to a dozen cases that I'm aware of, versus thousands of cases of women who are adults who have tuberous sclerosis and also have the associated lung disease or LAM. So that's the other thing to be appreciative of is that depending on when you are examining a patient, whether they be a baby or whether they be an older child or whether they be a young adult or they be an older adult, tuberous sclerosis can look very, very differently based on which manifestations are most likely to be present at that age range. As you heard, in 2012, we convened an update for the consensus conference with Dr. Hope Northrup, and we divided these into several different groups based on the different body organs. Now I have in blue here those that involve the brain, and we divided the brain into three parts because that is one of the areas that carries very significant disease morbidity from the first day of life often in many of these individuals. And so we divided them up into three different groups even though they were one single organ. Now because I only have 20-25 minutes with you today, I don't have time to go through all the different diagnostic criteria updates. I don't have time to go through the recommendations entirely of the surveillance. I'm just going to highlight some important parts that I think are worth mentioning today. All of this is published though in pediatric neurology. They're all open access and available for everyone to see. And as you heard, we are working on update, and I will share one piece of that with you today on the update that I think is worthwhile for you to know and start already implementing in your clinical practice. Now, why do we care about surveillance? And that's the topic that I have been given to talk about today. It's because tuberous sclerosis can be a lethal disease. There are various aspects, even though the growths and the abnormalities are considered benign, they're not malignant per se, but they can cause medical complications to the point of lethality. And this is a study also done by the United Kingdom where they compared what the natural decline in longevity, and that's what you see here in this. This is the natural curve for mortality of all causes. And you see that the tuberous sclerosis patients are shifted roughly about 10 years earlier. So on average, TSC patients will pass away from one thing or another 10 years earlier. But it's highly variable what that thing will be, and we'll talk about some of the more common causes of mortality. And our point for doing surveillance is to avoid this. Our point is that we have a lot more treatment options available to us, and we can also minimize the complications of interventions if we're able to intervene earlier in the course of somebody's disease pathway. I'll give you an example. One of the major manifestations criteria is cardiogramnomyomas. These are present from very early on in life, and many times these tumors can be inconsequential. But in some patients, they can either result in cardiac obstruction, where they have outflow flow obstruction and go into cardiac failure, or they can have fatal arrhythmias associated with disruption of the electrical conduction pathways of the heart. And so because of this, the number one cause of death in the pediatric age group actually is cardiac complications. And so what we want to do is know exactly when patients are having compromise of cardiac function so that we can have treatment options available to us, and we want to avoid a sudden death due to fatal arrhythmias. And so because of that, we do recommend that every patient, that upon the diagnosis of tuberous sclerosis, or when tuberous sclerosis is highly suspected, that they should have an echocardiogram, and they also should have an EKG. And that should be repeated until, for an echocardiogram, until the rhabdomyoma is resolved. And so what we do is we send all of our patients to cardiology to get their echocardiograms, and those, and the cardiologist will say, I want to see them back in 6 months, or I want to see them back in a year, and then repeat it. But sometime around, sometimes they're a year old, sometimes they're 2 or 3 years old. Many times the cardiologist says, I'm done, the patient looks fine, the rhabdomyomas aren't going to cause any further complications. You just need to make sure you do your EKGs every 5 years to make sure that there's not a residual arrhythmia risk that may pop up later. So that's our recommendations there, and that's the why we do surveillance for the cardiac disease. I'm only going to briefly talk about the lung disease. I'm primarily a pediatrician, but I do take care of adults in our TSC clinic along with my adult lung specialist. And in these patients, they're at risk of pneumothoraces, and there are very detailed recommendations written by this group that you can find. I think it's in CHEST. But every patient, when they get post-puberty age, so most of us start around 18 years of age, we will do a CAT scan of their lungs to look for cyst emergence. If there's just a few cysts and the patient is otherwise symptomatic, we don't repeat that until another 5 or 10 years. But we do ask them at every follow-up visit, are you having any breathing difficulties? Are you having any chest pains? And if they do answer that, and we can't easily diagnose what the cause of that is, then we will repeat the CAT scan ahead of schedule. It's recommended that we do pulmonary function tests on them every 5 to 10 years because sometimes the CAT scan may not be fully diagnostic of the degree of disease burden. And then we also start counseling from a very young age, even before they hit puberty, about avoiding smoking. We don't want them to have further insults to their lungs, in addition to what genetically may be in their future. So that's the importance of lung disease. We'll spend a little bit of time talking about kidney disease, and there's 2 types of lesions we see in tuberous sclerosis. One is the angiolympomas you see here in the first panel. You see a normal kidney tissue inferiorly, and on both kidneys in the superior lobes you see abnormal tissue, and that is an angiolymphoma of the kidneys. The other major common disease manifestation we see are renal cysts, and you see here on the CAT scan, on the MRI on the left, we see the large renal cyst. Down here you see a CAT scan where you can't see any normal kidney tissue. It's entirely filled with angiomyolipomas in this individual. And at the bottom, I'll talk about in just a minute about polycystic kidney disease. Now, these can be present from birth, but they accumulate throughout the lifetime of the individual. And the reason we need to know that, and why we need to do surveillance is manifest here, at least in one way. This is coming from Dr. Chris Kingswood in the United Kingdom, where you see in the far right is the curve of normal loss of kidney function in the general population of the United Kingdom. And what you see is over here that the patients with tuberous sclerosis actually have a much earlier onset of stage 3, 4, and 5 chronic kidney disease. And that is shifted significantly to younger ages by 10 to 20 years. And so this is what we need to be aware of. This is happening, and we need to prevent the complication of that, which is largely loss of renal function leading to dialysis and need for transplant. The other reason why we need to do surveillance in the kidneys is because the 2 to 3% of patients, they will have a form of kidney disease that's called that is identical to autosomal dominant polycystic kidney disease. This is because the TSC2 gene and the polycystic kidney gene, PKD1, sit next to each other on chromosome 16. And so it is possible for a patient to have a contiguous gene deletion syndrome where both TSC2 and PKD1 are both eliminated in their function. These patients will have a normal kidney ultrasound or scan when they're born, but by the time they are 1, and certainly by the time they're 2 years old, their kidneys largely look like this. And these are the patients that instead of needing dialysis when they're 30 or 40 or 50 years old possibly, these patients universally will need dialysis. They will go into kidney failure, and they usually do it before they turn 10 years of age. Some of them may make it to their teens, but they are going to have massive loss of renal function. This is why we need to do surveillance in these patients every 1 to 3 years to monitor their lifelong risk of angiomyopomas, as well as to monitor whether they're in this small subset of group where they have a very advanced form of cystic kidney disease with severe consequences. Here I show you how the two genes sit together on chromosome 16. I'm going to skip that for time purposes. So the recommendation is that every newly diagnosed patient must have an MRI, and MRI is preferred to CAT scan and ultrasounds, only because it can see so much more. Ultrasounds will pick up the biggest of the angiomyopomas and some cysts, but they will miss what we call fat poor angiomyopomas. Ultrasounds can't see those at all. It also becomes difficult more to track those over time, whether they're growing. And then we do kidney function tests, a blood test just to look for kidney filtration, even though that will be normal up until the time when the kidneys start to really lose their function very precipitously. All right, I'm going to finish my time talking about brain manifestations and the surveillance that we do there. There's actually 3 major brain manifestations in tuberous sclerosis. We have subependymal nodules that are present from birth, and then we have tubers, which are areas of cortical dysplasia that result from abnormal migration during brain development in utero. And again, those are universally present and present from birth. And then lastly are subependymal giant cell cytomas, or SEGA. These arise from subependymal nodules or SEN in about 15 to 25% of patients. And here we see the largest prevalence data that was done from the TSC registry, which was International Registry of TSC patients, that involved more than 2,000 participants. So this is why we do surveillance, is that SEGA can lead to lethal complications if undetected and untreated. These are slow-growing tumors. They are benign, but they grow near the foramen of Monroe. And because of that, the cerebrospinal fluid has to flow from the lateral ventricles into the third ventricle, and this tumor can block that flow, leading to hydrocephalus. This is one of my patients that was waiting to enroll into one of our clinical trials. So we don't normally just watch a patient and let their SEGAs grow. We do something about that. But this patient really wanted to avoid surgery and wanted to be enrolled in a clinical trial. And so this is just over 1.5 years of time frame to see that this growth was occurring. So what is the consequence if we don't do the recommended surveillance, which is MRIs every 1 to 3 years? Well, this is a patient that came to our clinic at age 4. And he had not had any previous MRI, so this was his first MRI that he got when he came to our clinic. And we found that there was a lesion near the foramen of Monroe consistent with SEGA. At this point, we could not say whether it was growing or not. We just knew that it was there and we were concerned. This patient, despite our efforts to get him to return back to clinic, and we made calls to their home several times to say it's time to come back so we can do another MRI, we can talk about treatment, the patient never returned. He did, however, go to see his pediatrician when he was 7 years old because he was having headaches, he was vomiting, and he was having blurred vision. And the pediatrician rightfully recognized that that was a neurological emergency, sent him to the emergency room where he had a CAT scan done. And here we see just after 3 years what that little tumor had done. And so this patient has not had to have his tumor removed. We were able to treat it with an mTOR inhibitor. He did still require shunting, and he still does have reduced vision in one of his eyes due to optic nerve compression that occurred when he was having this acute symptomatic. So this is what happens when we forget about these patients, when these patients don't come back and get the appropriate imaging. And the recommendation again is that this be done every 1 to 3 years. Now there is not any guidance yet for us to say who needs scans every year and who needs scans every 3 years. Most of our patients, we get them every year. Patients who have nothing at the foramen Monroe, we may feel much more comfortable about doing them every 2 or every 3 years. particularly as they get older and able to tell us more symptoms. But this, with a patient with a lesion like that, we would have scanned that patient within 6 to 12 months just to make sure and see what it was doing. And by all means, we would not have ever waited 3 years if the patient come back as requested. This is another patient that was being seen at a different neurology clinic, not at our center. And she was developmentally delayed. She's 10 years old. And mother noticed that she was less alert and she was more clumsy than usual. So she took her child to their child neurologist, and the child neurologist said, she's just developmentally delayed, and she's just going through a phase, and didn't really give it much credence to what the mother's concerns were. This did not sit well with the mother. She knows her child better than anybody in the world. And she knew something was wrong with her child. So she, the next day, took the child to the emergency room and said, something's wrong with my child. Can you figure out what's going on? And this was, she got a CAT scan, and then this was the MRI that was done the next day. And this is what they found on her MRI. Again, she was at a clinic that should have been doing surveillance imaging. Those recommendations were well known at that time. Yet that child neurologist was not advocating and actually ensuring that that child got the imaging as recommended. And so this is how she presented with hydrocephalus. She did go to surgery within the week. And as you see, post-operation, the tumor was reduced significantly by our neurosurgeon colleagues. However, in that middle panel, you'll notice that they did not remove the entire tumor. And SEGAs that are not completely resected will come back. And so she got a follow-up MRI 3 months later, and as you see, the tumor's already grown that much in just that 3 months from the remains of the previous surgery. At this point, she was offered to go to surgery again. Mother did not want to do that. She had significant bleeding associated with the previous surgery and had a very complicated intensive care course post-operation. And so she was looking to enroll in clinical trials instead of surgery, and that's what she did. And she responded very well to medication therapy. And to this day, now I think 6 years later, she still is doing wonderfully well and has not required any further brain surgery. So even though we may operate on these patients, they still need surveillance. They still need follow-up in case A, the original tumor was not completely resected and it comes back, or it is not at all unusual for them to have a SEGA on one side that was operated on and then develop at a later date a second SEGA on the opposite side. So surveillance needs to be done for all of these patients well to avoid these complications. Now moving on to the other major consequences of the tubers is high prevalence rates of epilepsy. And so the other surveillance that we do nowadays is electroencephalography in patients diagnosed with TSC. This is a study that we did. We enrolled 160 infants that were born with tuberous sclerosis, of which 42 of them had never had a seizure before they enrolled into our study. And we followed those patients, and then we had 10 of them that weren't able to be analyzed, 2 because they didn't meet the eligibility criteria for the analysis, 2 were lost to follow-up, and then 6 had been treated with seizure drugs before they ever had a seizure, so we couldn't ask the question, do EEGs tell us about seizures that are coming in the future? We found in the 32 that made the analysis, 20 of them went on to have seizures, 12 of them did not. So that roughly equates to a 63% rate of epilepsy before their first birthday. So we know seizures are highly prevalent in this group, and what I'm not showing here is that many times those seizures will not respond well to medication. Now, of those, 85%, we could tell that their EEGs were showing eleptiform activity before they ever had a clinical seizure. Contrast that with almost 60% who had a normal EEG and hence never developed any clinical seizures. So what that works out to is a positive predictive value of 77% and a negative predictive value of 70%. And so nowadays, we do recommend in all patients with tuberous sclerosis from infancy have EEGs performed at regular intervals to look for the possibility of developing epilepsy. And we know that the earlier we treat them, this is a paper that was done 10 years ago, that showed that the earlier we treated the epilepsy, the better off that they were to respond. So looking at the recommendations are MRIs need to be done every 1 to 3 years, EEGs need to be done at diagnosis and they need to be repeated afterward based on clinical need. And those MRIs need to continue until they're 25 years of age. Now, in the update, I'm giving you a preview of what the update is going to show with regards to neurological recommendations, and it emphasizes again how important it is for this imaging to be done every 1 to 3 years. It does talk a little bit about whether or not we need to have contrast administration. It's helpful. It does help you find and see and measure the tumors more easily, but in many patients you can assess whether or not they are having hydrocephalus or obstruction without the need of additional contrast. So that's up to the clinician to decide how helpful it is for their situation. But the new recommendation is that serial EEGs are going to be recommended for all infants in tuberous sclerosis, whether they've had clinical seizures or not. And that's to look for that pending seizure risk and to help us be ready to step in and treat those proactively if need be, based on any additional data that's coming. So inclusion, TSC is a genetic disorder. It does affect everything, and there are parts of how it affects the body that are important for us to prevent complications, and we do that by doing surveillance. And that surveillance is based on evidence that has been accumulated over the past 20 plus years. As we get new techniques, we'll update these things. As I mentioned, we've got new data for EEG importance, and the recommendation will be updated accordingly. And that's where I will stop. So thank you very much. I don't know if we want to have time for questions or if I run over.
I think 5 minutes we have. So if you have any questions.
Yes, ma'am.
Do you recommend surveillance for children for TSC parents?
Children of TSC parents? Of siblings?
Of siblings?
Yeah. Not universally. That's where I think my genetics colleagues and partners are very helpful because I start with them. We have a genetics counselor that comes to our clinic, and then we have a geneticist that comes to our clinic once a month as well. And I depend on them very heavily to say whether genetic testing is the first place to start for their evaluation, or whether we should do additional clinical testing first, and then pursue genetic testing later. But the genetics recommendation is that every family should have a 4-generation pedigree done, because we want to know, are we relatively low suspicion in those other children or high suspicion, and that will dictate. So I will say in my practice, most of my siblings don't get anything more than a genetic test. Occasionally, either because the genetic testing isn't available, our suspicion is still high, or the parents' anxiety is high, we'll do some testing, such as the brain, the heart, and the kidneys, which if they are negative for all 3 of those plus a skin exam, then I don't know any of my cases, maybe 1 or 2 rare mosaics that I've missed using just that basic screening. But I would not do it in everybody, and I really find my genetics colleagues very helpful to say we're suspicious or we're not suspicious.
So here we have families who do not have, they come to us as families.
Yeah.
Who do not need testing.
Yeah.
So we would go for the genetic test and then.
That's my, if it's available, that's the best way in my mind. Genetic testing is in traditional testing is good for about 85% of cases. With the next generation testing, we've been able to reduce that number probably as low as 6 or 7% that we miss. So there are still some cases we can't confirm genetically, in which case we move on to clinical. But I would not feel, you should not feel obligated that every sibling and every family is always be tested, unless you see that they have additional manifestations that make you suspicious. So that's where our data falls short. I've been challenged by my neuroradiologist colleagues saying it hasn't changed. Why are you still doing this? It hasn't changed. How many times are you going to do this? And simply the natural history imaging studies that are done today usually only involve 20, 30 patients. Many of them only look at one or two follow-ups. So we don't have evidence that tells us that. So I can tell you two things. One is, at Cincinnati, we have a data set that involves currently more than 1,300 scans over 20 years in 200 patients. And so we've started to analyze that, at least superficially, and we've asked the NIH for additional money to do it right and do it in everybody that we can follow, which will be more than 500 patients. And what we hope to get out of that is specifically saying, oh, if they have this and you've imaged it 2 or 3 times and it hasn't changed, only 1% are going to change from the future, so you can start to lengthen out their intervals. Until then, you have to just take my word on it, okay? Which is what we started to do now, which is if a child is very young, the peak age for onset is about 4 to 6 years of age, 4 to 8 years of age. So in those patients, we tend to scan every year, also because they can't tell us as well whether they're having blurry vision or the headaches may not be immediately available. And also, many of these patients also are developmentally delayed, and so they lack the words, they lack the way to communicate when something isn't right. So at the younger ages, our default is still to scan them every year, even if it's been normal up to that point. When they start to get between 10 and 20 years of age, and if they are able to communicate sufficiently that we would pick up that they're having headaches or other difficulties that they didn't have before, that they can communicate when things aren't being seen as well, and we have these previous years of normal MRIs, we've started to stretch them out to every 2 years for a few times and then every 3 years later. That's just our practice. Anybody with a suspicious lesion, though, we follow them every year, even if it has been stable, because we know the answer yet of which ones are going to grow. So, stay tuned. Great question. Wish I knew more.